And this is obviously a more efficient approach than having to move the kit from one vessel to the other. And obviously there's lower risk involved because we don't have to wire through disrupted plaque. But up until now, we've done atherectomy in the left main bifurcation in 2 limbs sequentially because it's obviously a very effective treatment. But I suppose now with the availability in Europe and soon hopefully in the States of Shockwave for the corneas, we potentially have a device which can provide effective calcium modification in the left main bifurcation without having to do double limb atherectomy. If we move and think about the osteorite, so currently if you're treating calcific osteorite coronary artery disease, and if you were treating that with the rotational atherectomy, say, what you have to do is you have to back off your guide catheter and then you're essentially free burrowing from the aorta into the ostium of the right coronary artery. Now that's possible to do, but it can be pretty tricky and there's some hazard involved in that. So again, if we have an effective balloon-based technology that we can hang out of the left main, inflate and oppose to the calcific plaque, that's a more controlled and possibly simpler way to deal with that type of disease. If we look at a vessel that's large with a large lumen, so say we had a 5-6 millimeter left main or a big dominant right coronary artery, where you still have a lumen of 2 millimeters, but you have huge amounts of plaque, 70 to 80% plaque, you can see that if you take, say, a 1.75 millimeter rotabur with a 7 French guide, there's a possibility, even with favorable wire bias towards the plaque, that you still might not manage to adequately modify that disease. Whereas again, if we have a large balloon that we can inflate with the IVL now up to 4 millimeters in size, you can imagine you can oppose that balloon and deliver your therapy more effectively to the disease. So as I say, I think in these specific situations, the left main bifurcation, the osteorite, large lumen vessels, and also in tortuosity where you have anxiety about performing atherectomy, say down a mid-LED where there's a 90-degree bend, I think that's where the balloon-based technologies, both the OPN, scoring balloons, cutting balloons, and now Shockwave, add some value and make life a bit simpler. So that's where we would choose to use those. Now, if we go back to imaging and think about how we're going to use that to help us decide in other lesions what device is best for us to use. So we start with IVUS. So on IVUS, when you're looking at calcium, what you are looking for is this very bright white hyper-echoic leading edge that you can see on these images here. What you're going to do is you're going to measure the size of the arc or the angle of calcium. You see here, this one is 270 degrees. You're going to have a look at the surface, and if the surface is nice and smooth, like the image in the middle, that usually suggests the calcium is quite thin. And particularly if you see these reverberations that you can see in that image, almost ripples around the calcium, like an echo of the calcium, is 360 calcium circle there in the luminal surface. That in that situation, the calcium is most likely to be thinner, whereas in the image in the top right, where it's more irregular and craggy, that tends to be consistent with thicker calcium when you compare IVUS to OCT. You're also going to be able to measure the length in your longitudinal view, and you're also going to be able to identify calcified nodules you see in the bottom right-hand corner there. So these are protrusions of tissue into the lumen with this bright hyperechoic cap on the top. So in OCT, you can essentially look and measure all the same characteristics. The one difference is that you can measure thickness. Because in OCT, you can usually see both sides of the calcium, like you can see in that middle image that I've drawn around. You can actually accurately measure how thick the calcium is in millimeters. But other than that, your assessment otherwise is going to be the same. And you'll be aware that Akiko Maharo and some of the Japanese groups have worked on these scores using OCT and IVUS to look at, using multivariate analysis, what predicts your final stent expansion and your final clinical outcomes in patients with regards to characteristics of calcium. So the OCT-based score found that the most important factor is how big the arc of calcium is. And if the arc of calcium was over 180 degrees, that got 2 points. If the calcium was thick, more than 0.5 millimeters, that got 1 point. And if the calcified segment is long, more than 5 millimeters, that gets another point. And what you can see from the graph there is that once you get to a score of above 2, your expansion is starting to fall off. And once you get to an expansion of a score of 4, you're really struggling to achieve adequate stent expansion, and that's going to affect your patient's long-term clinical outcomes. In the IVUS follow-up score that, the group presented last year at TCT, what they did here was all the patients had an ARC of calcium of more than 270, and then they went on to look at additional factors that predicted stent expansion. And again, the length of the segment came out more or less than 5 millimeters. If you have a calcified nodule, that can significantly affect your stent expansion if you don't adequately modify it, and if you're dealing with calcium in a smaller vessel. So the importance of these multivariate analysis and scores is that it focuses our mind on the aspects of the calcium that are important for us to pay attention to. So if we go back to our kind of algorithm, then when I am looking at a lesion and I'm assessing the calcium in IVUS and OCT, these are the things I'm going to look at. I'm going to look first at how big the arc of calcium is. I'm going to look at whether it's nodular or it's concentric. I'm going to look to see how thick it is, whether it's smooth or irregular in IVUS. And I'm going to look to see how long the calcified segment is. And that's then going to help me decide what calcium modification technique I think is going to be most appropriate and most effective. And we've got this array of options to choose from. So if we go through this logically, so coming back to what I mentioned earlier, if you've got an uncrossable lesion, you're going to use rotablation or laser atherectomy, because these are both suitable for that type of situation where you can't even cross your lesion with a balloon. As long as you can get a wire down, a microcatheter down in exchange for your rotowire, you're going to be able to modify that lesion. As I said earlier on, if we're dealing with left main bifurcation, osteal-right disease, very tortuous or angulated bend, or a large lumen, in that situation, I'm going to look to choose a balloon-based technology. And if my angle of calcium is less than 180, I'm going to use one of the cheaper devices I have available. So I'm either going to use a big non-compliant balloon, an OPN, high pressure balloon, a scoring balloon, or a cutting balloon. But if I've got an arc of calcium in that situation of more than 180, I'm going to have a low threshold now for me to use a Shockwave IVL balloon, which is as easy to use as any of these other technologies and is more effective. If we look at all these other lesions, which are the more common lesions we're dealing with on a day-to-day basis, the first thing I want to determine is whether I have any nodular calcium. So if there's calcium protruding into the vessel lumen, then I'm going to think about using atherectomy to try and shave that nodule down. And here in Europe at the moment, that involves us using rotational atherectomy. I know that orbital is becoming quite wide used in the US and is about to become available for us to use here quite soon. If it's not nodular and the calcium is concentric, again, we're going to think about the angle of calcium. So if we've got concentric calcium and it's less than 180 degrees, again, I'm going to use a more simple modifying balloon, and that's usually going to be effective. If the angle is over 180, I'm going to pay a bit more attention to whether it's thick and how long it is. So if the calcium looks to me like it's thin, and if it's a short segment, again, I'm going to use one of the cheaper modifying balloons. If though I start to see that the calcified segment's getting longer, I'm going to think of either using rota for me or Shockwave. And if I find that the calcium is both over 180, and particularly if it's thick and it's deep in the wall, I'm probably going to use Shockwave. And the reason for that, I'll show you some animations later on, is that one of the advantages of IVL is that you get penetration of the therapy into the deep tissue. So you can get microfractures right down into the media and into the vessel wall, which can be helpful with improving vessel compliance to help with stent expansion. So once you've used whatever your first modifying device is, it's very important then to make sure that you have actually modified the calcium adequately. And the way to do that is repeat your imaging. So repeat your IVUS or your OCT. And what you're looking for, very simply, is to see fractures in the calcium, like you can see here on the left. So you see breaks in the bright white hyperechoic leading edge of the calcium in the IVUS there. And on the right-hand side, we see these step fractures on the OCT. Now, one of the interesting things about IVL, we've noticed as we've used it more and more over the last couple of years, is that you get these quite classic, almost step-like fractures where you see the calcium looks like it's been pushed back into the vessel wall. Very characteristic appearance that you can see in that OCT image there. So repeat your imaging. If you have fractured the calcium adequately, go on to do further predilatation 1-to-1 with a non-compliant balloon and go ahead and do your stenting, and then repeat your imaging to assess your stent outcome. Now, if you haven't adequately fractured the calcium, what we will then do is we go back round the loop and we pick a different device. So if I've used atherectomy, I'm then going to go and use a modifying balloon. And if I've used a modifying balloon, I'll either use what I think is a more robust modifying balloon, or I'll then go on and use atherectomy. And you'll see in the literature, there's kind of a bit of an explosion of these kind of combination therapy case reports. So, RotaShock, Razor, RotaCut, all these combinations of devices you can use in these situations. So what I think I'll do now is I'll just show you a couple of cases, depending on how we got on time-wise, just to illustrate cases we've done where we've kind of used this systematic approach. So this first case is a man who was 70, came to us with angina and a positive stress test, and he had a diagnostic angiogram done by another centre that showed that he had a CTO of his mid and distal right coronary artery, and you'll see there how we've described the characteristics of the CTO. So importantly, for the purposes of what we're talking about today, this was a long occlusion, it was calcified with some tortuosity, and importantly, obviously, it's a CTO, so by definition, this is in the uncrossable section of our algorithm. So in this situation, I'm likely to anticipate that I'm going to use rotablation. So what I'm going to do is I'm going to try and cross the CTO. I'll have a microcatheter in place, and then I'll immediately exchange from a rotowire and just go straight to rotablation as the most efficient way to modify that type of disease. So here I'll show you the pictures. So this is a biradial case using 7 French guides, and you'll see that we've got contralateral injection from the left cornea. You can see the distal right filling. And I've crossed the CTO with antegrade wiring using a Corsair Pro 135 microcatheter and a Gaia second wire. You guys still got me?
Yeah, we still, yeah, Margaret, don't worry about it. This is typical sort of Microsoft issues.
You see my slides again, yeah?
Yeah, we do.
Okay, I'll just jump back to where I was. So we crossed with the Gaia and the Corsair Pro, and actually if you look at the video on the right, you can really see the calcium around the microcatheter down the descending limb of the right coronary artery, moving around it. It's a very heavily calcified vessel, and actually it was very difficult to get the microcatheter through that distal segment of the right. So without wasting time, I then exchanged for the rotowire. We debulked with a 1.5 RotaPro burr, the new version of the rotablation, very quick. And then we pre-dilated with sequential non-compliant balloons. You can see the extent of the disease. And then even despite that, we had to use a guide extension. You can see I've delivered a guide extension away down to the distal vessel to deliver overlapping stents from just before the bifurcation all the way back to the ostium. And then we post-dilate sequentially. I was guided with non-compliant balloons. And ultimately we got a really nice result. So a nice example of using rota for critical uncrossable disease and getting nice calcium modification. So the second case was a man who's 65 who came in with a non-ST elevation MI, and he had calcific disease both in his circumflex and in his LAD and his left main. His case was discussed and the decision was made that he should have complex PCI rather than bypass because of multiple other comorbidities. So when we looked at his angiogram and on his IVUS, we felt the disease in the circumflex was more mild to moderate. So there was an arc of over 180 degrees, but it was over a very short segment, and also it looked like the calcium was thin. Whereas the disease in the left main LAD, we thought there was one segment where the arc was big, and also the extent of the disease was long. So there was about 40 millimeters of disease that we needed to treat. So in this situation, going back to our kind of systematic approach for the circumflex, we've got an angle of more than 180, but the calcium's thin and it's short. We're just going to use a modifying balloon. Whereas for the LED, again, the angle's over 180, the calcium's thin, but we've got a long segment of disease. And in that situation, I think the most kind of time and cost effective approach is just to perform atherectomy in that situation. So we're going to do a hybrid approach. We're going to use a modifying balloon in the circumflex, and we're going to use atherectomy in the left main LED. So what you see here is the image on the left is a 2,5 non-compliant balloon in the circumflex, and you can appreciate right in the middle of the balloon that there's a waste of under expansion, and you can see that on the IVUS on the right hand side. So there's an area where there's quite a large arc of calcium here. So we were unhappy that we'd adequately dealt with that. So we went on to use a Scoreflex 2,5 non-compliant balloon. This is the scoring balloon that we use most commonly here in Europe. And what you can see is the way the balloon works is it's a rapid exchange balloon, but your wire comes out just immediately after the balloon tip, much like with when you use IVUS. And your wire becomes the second wire on the outside of the balloon. So you have two wires that are cutting into the plaque. And it's actually a very deliverable device, and it's really quite effective despite its simplicity. So you can see here we've inflated the 2,5 Scoreflex non-compliant balloon, and you can see that's expanded really nicely. And it's then allowed us to deliver a 48mm drug-eluting stent, which again you can see looks like it's expanded well. So we go on to postulate that with a 3 non-compliant balloon, having used an IVUS to size everything. We're pretty happy with that. You can see there's some disease in the ostium of the circumflex, but on IVUS that all measured well, and the front end of the stent looked fine. So our plan here was to keep this simple and try and do a provisional left main LED rather than converting this into a very long 2-stent bifurcation. So on the right hand side, what you can see is we've delivered a cyan blue with a microcatheter down to the apical LED. I've exchanged for the rotor wire, and I've used a 1.75 burr to make sure that I adequately modify the calcium in the distal left main ostial LED. And actually you'll see on the IVUS that I think we see that we've got pretty good modification where the calcium's at its worst. Here we've got a nice fracture there. That was originally a 360-degree arc, and you see we've broken it up at 1-2 p.m. And there's a couple other fractures as we come through. So we're pretty happy that we'd adequately dealt with that. We put a 3032 stent into the LED, and then we stented back into the left main with a 4.0, again sequentially postulating. And we were pretty happy with that end result. There's that kind of slight bend with a very modest under expansion where the worst of the calcium was, where you see that huge septal coming off the LED, but on the IVUS that all looked good, and you can see in the caudal view that the left main looks nice. And again, you can see there's a bit of disease in the osteoproximal circumflex, but we didn't want to convert that into a 2-stent bifurcation with the associated higher restenosis risk, especially in the presence of calcium. And I'll just very quickly run you through. This was just the IVUS. So that's that slightly eccentric bit at the bend in the LED, but the minimal stent area here was good. And one of the things about dealing with calcified disease is you sometimes should accept appearances like this, not go for absolute perfection, just because there's obviously a risk of causing rupture or perforation in the coronary if you push too hard. And you'll see as we come out through the proximal LED into left main, it all looks nice, and we get really nice apposition with the 4.0 in the left main. So nice example of how to use a hybrid approach with different devices in different locations. So quickly, a couple of examples of larger vessels where we've maybe used Shockwave. So this was a 67-year-old man, previous PCI to his LED in 1997, CTO PCI to his circumflex in 2012, came back with an NSTEMI in April, had PCI performed again to the LED and to his right coronary artery, and then was referred to us to have CTO PCI to the occluded stent in the circumflex, and then treatment of the left main bifurcation disease. So what you see here is that the stents in the LED are patent, but you'll see that they've left the osteoproximal LED disease back into the left main. The reason they've done that is they want to leave me access to the circumflex to open that CTO in the circumflex, which is going to be more difficult if you've stented across the circumflex. And you can see the circumflex is occluded, and there's a stent in there from 2012. And we're single access here because there was no collaterals in the right coronary artery. All the collaterals filling the OM retrogradely are coming off the diagonal branch. You can see that in that LEO cranial view. You see the collaterals coming around the lateral wall and filling the OM retrogradely. So we've got occlusive ISR in the circumflex, and we've got left main bifurcation disease. and we suspect there's quite a lot of calcium involved. So in terms of the circumflex, it actually opens surprisingly easily. I was able to get into the nose of the proximal cap, and then I used the crossboss device, which spun all the way through the stent and went true lumen to true lumen. So I was absolutely delighted with that. It saved me a much more complex procedure. And what you can see on the right-hand side is the IVUS after we've ballooned and opened the circumflex. And there's occasional dropout in this IVUS run just because we were having problems that day with the catheter. But a couple of things I wanted to show you. So one is that's within the old stented segment. And you can see as we come up all the in-stent restenosis. But see here, this is a beautiful example of a hematoma. This appearance down between 6 and 9 p.m. We see this a lot in CTO PCI. So we've created hematoma in the neoatherosclerosis within the stented segment. And the other thing I wanted to show you was when you get in front of the stent towards the ostium of the circumflex, there's a lot of calcium. So as we come back towards the left main, you'll see there's a lot of calcium. So that's the left main bifurcation. You see the wire from the LED coming in at 11 p.m. So you can see that we're dealing with quite a lot of calcific disease at the ostium of the circuit at the left main. So if we go back to our algorithm here, we've got a left main bifurcation, we've got a large arc of calcium, and I'm going to, in this situation, reach for Shockwave because it's going to be quite a simple and effective strategy. So just to tell you a little bit about Shockwave, because I know you've as yet not been able to use it in the coronaries, but I think hopefully with Disrupt CAD3, that might change soon. So it's a very simple technology to use. You have this console you see here in the picture. You essentially plug the wand into the front of the console and switch it on and it's ready to go. The balloon catheter you prepare like any other balloon that you would be putting into the coronary. The wand connects with a magnetic connection to one of the Y connectors at the back of the balloon, and you can connect your indeflator inflation device to the other arm. It's as simple as that. And you switch it on. And when it's ready to work, both the green lights that you can see there in the console light up. And you take it on the wire as a rapid exchange like you would do with any other balloon. At the moment, it comes in 4 sizes, 2.5, 3.0, 3.5, and 4.0. And all the balloons at the moment for the coronary are only 12 millimeters long. And that's one of the things about it. If you've got long segments of disease or bifurcation to disease to treat, sometimes you're going to have to use multiple balloons and it's expensive. So for us, that's a definite consideration. And it's 6 French compatible, which also obviously is also helpful when you encounter calcium when you're not expecting it during kind of everyday PCI. So just to tell you a little bit about how it works. So you track it over your regular, any wire you like, you put it in position and you inflate the balloon to 4 atmospheres. You then, on the back of the balloon where it connects to the wand, there's a button which lights green, and you press that button and it will deliver 10 pulses of therapy. Each balloon has 8 sets of 10 pulses of therapy. So it will deliver the therapy, and once it delivers 10, it switches itself off, and that green light that says therapy in the front of the console will go orange and tell you that that round of 10 therapies is delivered. Few seconds it resets itself and you can go again and deliver another 10 up to 80. And if you want, you can move the balloon around and deliver the therapy in different locations. And what the balloon's doing is it's delivering high frequency waves into the vessel wall. The more calcium you have, the more effect it has, because the calcium reverberates back and forward. The radio frequency waves reverberate back and forward as they bounce off the calcium in the vessel wall. And I think, as I said earlier on, one of the things about it which is helpful is that as well as dealing with intimal calcium, you get microfractures deep into calcium in the media as well, helping with vessel compliance. So you'll see here that you, as you press the button on the wand, the device delivers the therapy, and you'll see on the monitor that it flashes every time you deliver therapy. So very simple. So this is just us doing it in the lab. So you'll see that's the wand. It's in a sterile sleeve that you would use for ultrasound or for echo. And it's a magnetic connection. We just cut a hole in the bag like you have with the OCT, and you just connect it up. And you'll see we've got our indeflator device lying on the table, and that's just connected to the other arm. And very simply, you take your balloon into position, you inflate the balloon to 4 atmospheres, and then you'll see the green light, the green band of light around the wand that's lying just on the table there. I'm going to pick that up. There's a button on the back, and I'm going to press that button, and it's going to deliver therapy. So you'll see me doing that now. You'll see the green light flashes on the back of the wand. Now, if you look at the ECG there, you'll see you get these things they call shock topics, which is ECG capture as you deliver the therapy. Now, there's been 30,000 IVL balloons used worldwide, and the company tell me they've had one reported episode of VF. They've had a few instances of AF, whether that's incidental due to ischemia or due to the device, they're not certain. Certainly with large volume use around Europe and around the world so far, there's been only one officially reported episode of ventricular arrhythmia. Okay, so back to our case. So we took a 3.5 shockwave from the left main into the circumflex across that calcium we saw at the ostium. And to be cost efficient, I delivered 60 pulses there. I took it out and I put it on the LED wire and delivered the other 20 from the left main into the LED, feeling that it was the less calcified segment of the bifurcation. And I think as we come through the IVUS, you'll see when we get to the ostium that we've big difference in the size of the ostium. See the luminal gain after the IVL compared to what we had at the beginning, and we've fractured it. So I'm very happy that I've adequately modified that, and I can now go on and do my left main bifurcation stenting. So we actually decided there was so much restenotic tissue inside the circumflex stent that we felt we wouldn't get a good result with drug-eluting balloons, which is what we would normally do here. So we decided to re-stent. So we stented across the old stent in the circumflex, and then stented from the proximal circumflex into the left main. I performed a POT with a 4.5 non-compliant, and my intention here was to perform colot stenting. So I then rewired the LED and placed a 4018 to complete the colot stenting from the LED back into left main, again performing a POT with a 4.5 NC, rewired the circumflex, performed kissing balloons, and then a 5 POT in the left main. You see we get a nice end result. So the IVL really worked really nicely in this case, and both that and the fact we got through the occlusion quickly made it a really nice, efficient procedure. So I'm going to show you one last case and then we'll stop and see if there's any questions. This is a 78-year-old woman who presented with inferior ischemia. She had a previous bypass and has a blocked graft to the right coronary artery. She'd actually come for PCI with one of my colleagues recently for rotablation to her osteo right, but they felt that despite the rotablation, the balloons were still under expanded and elected not to proceed on and stent it at the time. So we brought her back to do IVL. So you can see there's some disease in the proximal right coronary artery, but if you look closely, the ostium's funny, it comes off at an angle, but you can see there's a real lip of calcium on the angiography. And then when you look around the views and when we looked on intravascular imaging, there's a real hoop of calcium around the ostium of the right coronary artery. So you'll see here on the IVUS run, I'll just pull this back through so you can see. So this is the disease that we see proximally angiographically. We come back through to the ostium. So a nice healthy bit here, segment here. And then you see this calcific tissue here, very tight kind of napkin ring at the ostium, very classical appearance that you can get in the ostium of the right coronary artery. So we took IVL, and as you saw in that previous video, hung it across the ostium, inflated it to 4 atmospheres, delivered the therapy, 8 rounds of 10 shocks, nice and controlled, and then repeated our IVUS. I'll speed through that to show you what we saw, and you can see again that we've managed to significantly modify that ostium. You see the multiple fractures and the big luminal gain after the IVL therapy. So we went on to stent it, and you can see angiographically it looks really nice. And if you see if I can show you yeah, it's just an IVUS still there. Okay, so nice, efficient way of dealing with that. And I suppose that was a kind of staged rota shock case, having rotablation the first time and then shockwave the second. Okay, so just in summary then, so we've been working through this idea about thinking more carefully about how we approach these lesions. One, I suppose, to not overuse the technologies, because obviously fiscally we have to be responsible, because certainly atherectomy and shockwave for us is expensive, but also to have the confidence to go on in these complex cases to proceed with our stenting and make sure we're going to get good stent outcomes and therefore long-term outcomes with our patients. So I hope that's a useful kind of introduction to our thought process around this field, and I'd be delighted if there's any questions people would like to ask.
Thank you, Margaret. That was great. And maybe leave the algorithm up a little bit so we can discuss around it. We have like I said, I'm going to have Aisha come on and put her video on. We also have a guest panelist who occasionally joins us. And I wanted to ask him to maybe make a comment if he's around. Antonio, you around?
Yes, yes, I listen. Thank you very much. And Azim, congratulations for keeping this journal club on a weekly basis. I like the lecture. I think very informative. I just want to add one aspect of our practice is the use of the cutting balloon at high pressure. This has really made a difference. And the addition is to use multiple devices. It's not rare that we go with the rotablator, then we go with the Shockwave, and then we need the OPN.
Yeah.
It's not common, but you should not look as one device procedure. Calcified lesion needs a combination of devices.
I think that's a great comment, Antonio. I think that's a great, and there's a lovely little paper actually that showed just what Antonio said there, that if you rota and then you use a cutting balloon, it's a very strong predictor of good stent expansion of over 90% in all your cases. I think it's got like a odds ratio of 7 in favor of a better outcome if you do combination therapy in that type of situation. So I think that's a really great comment. I think when we were bringing in Shockwave in our institution, because of all the kind of fiscal constraints in the NHS, we had to put a business case that we would use it instead of other technology, but we don't at all. We use combination therapy quite frequently, and I think that is definitely the future as we deal with more and more calcific disease in the older patient population.
So maybe before I pass it off to Aisha, I'll ask you both a question about that. So first, Margaret, traditionally or years ago, there was the teaching that you shouldn't do cutting after rotablation because you increase the risk of rupture. If I could have you maybe comment on that. And then Antonio, if you would just comment on this high pressure cutting balloon for the fellows, because also there's been a traditional thinking that you shouldn't go to high pressure with cutting balloons because you can cause ruptures. Are you undersizing the balloon and so on? So maybe Margaret first.
Yeah, so just like Antonio was saying, we frequently use cut or scoring after rota. In the very calcified cases, almost routinely in the left main bifurcation often as well. And I have to say, I've had very, very few, I can't recall the last time we have had a problem with that technique, despite the fact we use it often. I think the key is to know what you're dealing with. So don't use it when you don't need it. So if you use intravascular imaging to guide what you're doing, if you've fractured the calcium, you'll very well fractured it all after your first device, and you take a 1-to-1 non-compliant and you get a really nice expansion, then don't go on and use other therapy if you don't need it. I think that's when you'll cause hazard. But I think if you need it, it's certainly in my experience, it's a safe approach.
Yeah, I say that cutting balloon we almost never inflate the cutting balloon less than 20 atmospheres. If you open a cutting balloon, it has to go to high pressure. But you have to be careful because when you go to high pressure, the cutting balloon is a semi-compliant. So we need to undersize 0.5 millimeter. The other rule is that when you deal with a severely calcified lesion, if you want to do a good job, you always take the risk of rupture. So you will have 2 or 3 ruptures every year. If you don't have 2 or 3 ruptures every year, it means that you are not doing a good job.
And Antonio, what's your experience with IVL? You like it?
I like it, but in severely calcified lesion, even when you go at 4 atmospheres, sometimes the balloon ruptures.
Yes, yes,
This ruptured balloon is a big expense because
yes,
the company does not reimburse you.
yes,
And so my algorithm, if the standard balloon does not go, I use rotablation. After rotablation, almost always I use a cutting balloon at high pressure, then high pressure balloon. If I have the impression, or if I do IVUS and I see a circumferential calcium of more than 180, then I use lithotripsy, especially if I have a big vessel. If I have a big vessel, it's not rare that I use rotablator first and then lithotripsy.
yeah. The balloon rupture thing is definitely a real phenomenon. We've seen that too. And the problem is for us, is I'm sure it's the same for you, it's £1,200 per balloon. So if you take it out and it ruptures on the first or second round of 10 shocks, and sometimes occasionally we've had it rupture and we've had a nice hydraulic modification of the plaque,
Yeah.
and it's okay. But if it doesn't and you haven't, then you have to take another balloon out. It can be expensive.
Yeah, but I think a lithotripsy is a very important device. It's very safe, and especially when you're dealing with big vessels like left main, it's really a must. When you do IVUS after you have used lithotripsy with the appropriate indication, the stent is round,
Yes.
nice and round. And I believe that the more round you get, the less hyperplasia you will have.
Yeah.
I don't have a good study. I wish someone would do a study to evaluate the symmetry and the roundness and the late loss, but I'm sure that there is a relationship.
Yeah. And I think, yeah, I agree. I think the IVL is a very, very useful device. And I think the other thing we found is the people in our group who are lower volume operators, it's so easy to use that it's a very useful tool for them. So say it's the middle of the night and you have a primary PCI that's 85 and has calcified disease, then where they might not be confident with atherectomy, then they can take out the IVL and get themselves out of a difficult situation. So it's very user friendly, I think, too.
Aisha, it's all yours. Sorry, we've been talking a lot and we haven't given you a chance.
Oh, that was fantastic. And thank you, Dr. Mcentergart, especially for walking us through the algorithm. That was fabulous. I especially liked how you told us about the balloon-based strategies, especially when there's an arc of less than 180 degrees in left main and ostial RCA. So I think my question, and in fact, there's a comment in the Q&A as well, how approach in choosing which balloon, I mean, aside from IVL, in a smaller arc of calcium, whether it's a cutting or a scoring balloon, and what are the pros and cons of choosing each of them?
So good question. And if you ask 5 interventional cardiologists who deal with calcium, they'll all give you a different answer. So Antonio obviously uses a lot of cutting balloon, and I like the cutting balloon too. I think the Wolverine, the new version of the cutting balloon, is much improved on the Flextome, which was the old version. Flextome was quite difficult to deliver to the mid to distal vessel, but actually the Wolverine is very deliverable. They've really improved the crossing profile. What they've done is the blades, when the balloon has been folded, the blades are within the folds, so that when you're tracking it, you don't have the friction between the blades and the tissue. We use a lot of Scoreflex in our institution. We got a very good fiscal deal on a large batch of Scoreflex, so we have quite a high volume experience of that this year. And I think the advantages of that is it's very trackable. I think it tracks even better than the Wolverine. So I think if you're dealing with more distal disease in tortuous vessels like you saw in that circumflex, it's helpful in that situation. I routinely predilate anything that looks at all calcified with non-compliant balloons, even if I wasn't going to go on and use something more. And I certainly have colleagues who are fans of the OPN high pressure balloon, but for me, that's a kind of final bailout balloon. I tend to use that if I've used everything else and I feel like I need a final hit. So for me, I'm going to use IVL if I feel the calcium is bad enough to need it. If I don't think it's bad enough to need it, I'm going to use scoring or cutting. and reserve OPN for the very occasional case. Antonio, what are your thoughts on the other balloon technologies?
I use OPN only when it's really needed. I'm always a little bit nervous to go at 40 atmospheres.
Yeah.
I said perforation and ruptures. I know I said you should not have ruptures. Honestly, I think if you do a careful evaluation by IVUS and you use a mature approach, you should almost not have ruptures because it's a terrible complication.
Yeah.
I think PCI has to become a safe technique, is a safe technique.
Yeah.
And few years ago was not okay, but was justified. Now I don't see justifications to have ruptures.
Yeah.
So you need really to be mature, do 2,000 PCIs and have no ruptures.
Yeah.
That's a mature operator.
Yeah. Yeah, I agree, Antonio. I think the idea of just pushing at higher and higher pressure is a bit unsophisticated, especially when we have other technologies that can weaken the resistance and improve the compliance in a more controlled way.
Yeah, I'm terribly nervous to use the OPN. I use it, but I get an adrenaline when I go to, especially when I have to deflate the balloon.
Yeah.
When I inflate, there is no problem.
Yeah.
But the deflation, it's...
So I'm glad you justified your previous statement about 2 ruptures are okay, yeah? Because I have a lot of questions to answer later.
Unfortunately, you may have, but you should have nowadays 2 or 3 years in a row without a rupture.
Yeah.
I try, but I don't try.
And Antonio, this question that came up, have you seen, you're using now, you've been doing a randomized study with cutting balloons at high pressure. Have you seen the balloons breaking or disrupting or the blades disconnecting of the newer balloons?
Not really, not really. And I use it a lot. I use at least 3 times, 4 times a week at high pressure.
Okay.
No, I didn't have. I'm sure if someone saw it, it can occur. In the old time, one of our senior operator inside a stent had a ruptured cutting balloon, and the cutting balloon did not come out at all. He had to take the patient to surgery.
Right.
But only one case, but I remember, was in ostial circumflex.
Okay. Aisha?
Yes. There's a question about, I think it came up when you were speaking of IVL in the left main. How long can you stay up? I think how many pulses would you, how many rounds would you tolerate in the left main? Yeah.
It's a good question, actually. So up until recently, when I've been using it in the left main, I've just been using it as I would anywhere else. So put it across, give 10 pulses, deflate, patient seems stable, repeat until I'm happy I've delivered adequate therapy. I was on another conversation with some other people recently, and it was suggested, some people were saying they were given 5 short sets of pulses, and then stopping rather than 10. So 5 shock stop, 5 shock stop. But I have to say, I've been doing 10s and I haven't as yet had a problem, like for instance with irreversible ischemia or hemodynamic collapse. Though obviously with all these complex interventions to left main, if the patient's got LV dysfunction that's significant, that can be an issue. But I haven't had a problem with that when I'm delivering 10. And also, I'll usually leave the balloon in place. I don't usually pull it back, because sometimes, like everything else, if you deliver therapy and bring the balloon back, then sometimes it can be slightly tricky to recross if the balloon's unwrapped in a certain way. So yeah, so I've found it's been okay in that situation. I don't know if Antonio's got anything to add to that.
No, I think it's if you just take a look to the blood pressure, usually, unless you have an occluded right coronary, people tolerate left main occlusions 30 seconds most of the time they tolerate.
Yeah, yeah,
So I think it's, and especially you get this conditioning after the first inflation, the second one is better. So I don't think it's a real issue,
yeah,
except in some situations, of course it is, but most of the time it's not.
yeah. And
I, we just published a large case series in JAK intervention with Escaned on IVL in left main. And you'll see there the actual risks of patients decompensating or going into shock or having severe hypertension was actually quite low. So
yeah,
it's actually pretty safe. I mean, patients tolerate 15, 20 seconds of left main occlusion better than you'd expect. I mean, I know we used a lot of drug-coated balloons as well in left main for restenosis and so on. And that sometimes we leave it up for 40 seconds and we'd be surprised how patients were tolerating it. I think the way, like Antonio always says, if you're looking at the balloon and the wire in the coronary is still moving, you can still leave the balloon up. It's when the wire stops moving that's the problem.
and the only other comment there is that it's actually, when we've had patients that we have issues with Impella because of costs and things. So if we have the patient who say has severe LV dysfunction, and like Antonio said, a blocked right and left main bifurcation disease, we have to get in and try and fix it with only backup support, hemodynamic support, then we've actually found that IVL has been quite an effective strategy there because you can work very quickly, so you get your wires in, balloon, 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 and you don't have the whole, the slightly more prolonged procedure you do if you're using an atherectomy, which we use usually in high volume. But I think in those cases, it's very useful, actually, very useful, efficient way to deal with the left main in that type of case.
Thank you. Just to expand on the IVL further, question on the chat if it's associated with an unusually high frequency of atheroembolism.
Of
Shockwave.
what embolism?
Atheroembolism.
Okay, so this is a really interesting question actually, and we've been looking at this. So I did a little study a few years ago where we did ROTA in complex cases, and we looked at periprocedural MI, and we did troponins and ECGs, and they all had MRIs before and after, and we looked for injury, and we found that a certain proportion of patients had periprocedural MI and a certain proportion had injury on their MRI at a week. And then we repeated the MRIs at 6 months to show most of it had healed, except for in a small proportion. So and in those cases, we measured IMR, so microvascular resistance after ROTA, and at the end of the cases. And we saw a bit of a blip and your IMR went up and then it improved at the end of the case. So in fact, there's been some discussion with Javi and the guys in ALST, who are interested in physiology, where we're going to do a pilot study of the same thing with IVL to look to see if you do get any microvascular disruption. The thinking is, the proposition is you won't, because you're not actually ablating and disseminating the plaque in the same way you are with atherectomy. You're actually fracturing the plaque in place and then increasing the compliance of the vessel and pushing it out of the way. So it'll be interesting to see if we do see any physiological change with it.
Thanks. And I know you did say that Shockwave was a good strategy for non-high volume operators. There is a question on the chat about what your approach is when you encounter significant calcification of a culprit lesion in the context of primary PCI.
So I just manage it the same way I would in stable PCI. So whatever needs to be done, you do it. So if you need to ROTA, you ROTA. If it's more suitable for IVL, use IVL. So I think most kind of complex high volume operators will do that now, and our lab's certainly set up for doing it, that type of stuff out of hours. But in their group, we have a group of 12, and in the group there's maybe 4 people who are low volume guys who come 1 day a week, and they're not comfortable with ROTA and things because they don't do it enough in the middle of the night when nobody's else there to support them. So for them, IVL has been very helpful in those cases, where they're stuck.
All right. There is another question about imaging. sometimes the imaging catheter and the wire, they're biased to the outer edge of the vessel of the arc of calcium, so you don't necessarily get the full picture. Have you noticed that rotablation can be less effective in these cases because sometimes the burr is also biased away? I think the Guidewire bias, basically.
Yes,
Could you walk us through that?
So yeah, so that's a very important point, and it's something when you're dealing with these cases you'll learn with time, you know, about how wire bias can be helpful but also can be unhelpful in cases, and sometimes you think it's going to be helpful and sometimes it turns out it's not. So you have to choose depending on how you feel the wire is interacting with the plaque on your imaging. You have to incorporate that into your decision making. Ultimately, obviously, if you choose to rota a case and you can't get adequate modification because of wire bias issues, then you're going to have to change and use a different device to be effective. Antonio, what's your thoughts on that? The wire bias atherectomy?
I think it's a reality. We don't have any OCT data, but with rotablation, I do more and more rotablation also on the way back, not only on the way in. And this is classic for orbital atherectomy to do it on the way back, but most probably may be a little bit beneficial also for rotablation. Unfortunately, the burr is not completely coated, so the efficiency is not great, but maybe I don't think there is much to lose to rotablate on the way back, especially when you have a lot of wire bias.
Yeah.
All right, I do have another question. What is your approach to calcific ISR? As a rule of thumb, how would you approach it?
Okay, so this is an interesting question because it kind of depends on what you think the mechanism of the ISR is. So if when you encounter in-center stenosis, obviously the first thing you want to do again is image. You want to try and assess whether you're dealing purely with calcific neoatherosclerosis. So your original stent was fine, and you've just got neoatherosclerosis has become very calcified. And in that situation, you're essentially going to manage it the way you would any calcium. The other situation obviously is that you have the original stent has been underexpanded due to calcium, and that can be a different situation because obviously you need to deal with the ISR, but you also need to deal with the old underexpanded stent. And that for me is where there's a really nice niche use for IVL off-label in that situation. So if we think we've got underexpanded stent in that situation, we would use IVL. And certainly in my practice now for those cases, usually, regardless if it's calcific neoatherosclerosis with or without stent under expansion, I'll use IVL and then use a drug-eluting balloon unless I feel there's outflow and inflow disease or it's an old bare metal stent or some other reason that I want to put on another drug-eluting stent. Antonio?
I think lithotripsy is certainly the most elegant. You can also use, if you can afford laser with contrast, is quite effective. And the cheapest one is rotablation. It's not so elegant, but is most of the time effective. So rotablation, lithotripsy, or laser, all three are okay.
Yeah.
All right, thank you. Just one last question, if you don't want to. What about calcific graft vessel? I mean, you supposed to be reserved in intervening in a graft vessel, but if you had to, in a calcified saccophenous venous graft, please. Yeah.
So I've previously rotated vein grafts before. It's like the calcific restenosis of old stents in vein grafts, not native vein grafts. So you can do that, but it's risky and only in extreme circumstances. Laser obviously is often a good option when you're dealing with grafts, but now IVL for me. So we've just actually yesterday had a paper accepted to CCI of a series of IVL and vein graft cases, either calcific vein graft restenotic or restenotic calcific vein graft disease. So I would now use IVL as my first choice in calcific vein grafts. Antonio, any?
I think the same as you said. I think
And I must admit, we just seeing less and less vein grafts. I mean, I was trying, you know, I remember when one of the first papers I wrote when I went to work with Antonio as a fellow was a large case series of vein graft intervention, which I actually published in Circ Intervention because it was of so much interest. And then, you know, if I do one vein graft a year, it's a lot right now.
Exactly. Exactly.
You're absolutely right. They disappear. I don't know why, but I think they stay open. They don't get disease anymore.
We've got so good at native vessel PCI, we don't need to do the veins anymore. Eh? It's
Exactly.
only very occasionally, like your kind of 88-year-olds, you know, where you feel the CTO is not appropriate, or it's, you know, only those cases now.
Yeah, absolutely. I think we're going to end there. We've run a little bit over time. Margaret, thank you so much. That was a phenomenal talk. We all learned so much from your experience, and hopefully we can get you back again and you know, to talk about CTOs or one of your other areas of passion. It would be awesome. Aisha, thanks for the excellent moderation. We appreciate it. Antonio, thank you very much as always for joining. Don't forget you're on next week, Antonio.
Bye-bye. Take care.
Okay. Bye-bye.
Thank you. Thanks. Bye.
Thank you.
Bye. Bye.
Bye.